So I wanted to just share with everybody kind of a weekly update. Thought this would be good just to kind of get us all on the same ground. This is from our state dashboard. And so any of our experts that have anything to comment on this, we would appreciate it. This was taken yesterday, so isn't the most up-to-date information, as I think they updated on Mondays. But just to kind of give you an idea of test positivity, 14-day with a 7-day lag. Most of us are in the red, as you can see here, above 10%. Here on the next slide, this is just the trend of the same information. So you can see back in September, many of us were in the white with our test positivity rate, but then as this data goes along, many of us jumped into the red, start highlighting the red above 8%. And so hopefully we start seeing more white as the weeks drawn on and we all get vaccinated. This is just a quick dashboard from the facilities reported COVID-19 cases. As of yesterday, 525 residents and patients, 15 staff deaths, and over 9,000 confirmed cases within all these types of facilities across our state.
Yeah, so where do these numbers come from? Because we look at these and they're never correct.
I could add to that. I believe these numbers come from your red cap reporting. So whoever's reporting in red cap, I believe that's where they pull these numbers from.
Okay, but that's what we thought too. But if you look at our facility, it shows that we have two deaths from staff, and that's not true.
My guess is you should get in touch with the red cap, whoever your person is, because something must be glitched in the system if you're experiencing the incorrect information. But as far as I understand, this is your red cap reporting gets directly pulled into this.
Cool. Yeah. Thanks for bringing it up. Accurate reporting is definitely an important thing, and definitely keep that in mind as we look through all these numbers as well. And kind of thinking about our numbers, I think that was a great transition, Anthony. I wanted to also kind of throw a little bit of a quick COVID-19 update for you all. We're going to talk a lot about vaccines here in a second, but just wanted to show this kind of note to the editor about potential for racial bias in pulse oximetry measurement. I know a lot of us use those pulse oxes, those things we put our finger, our earlobe, sometimes our forehead to get an oxygen saturation. Mostly, kind of used it ubiquitously throughout all of medicine, inpatient, outpatient. When it was initially looked at, sound to be pretty accurate, especially when people had normal oxygen levels. But in general, there's limited randomized controlled trials, RTC, about the effectiveness of pulse ox outside the ICU. And so some people in Michigan were taking a closer look at this during COVID-19 with the increased use of pulse ox and trying to decide how often are these pulse oximeters missing occult hypoxemia or decreases in oxygen level that is not detected by that pulse oximeter. Essentially what they found out for those with pulse oximetry greater than 88%, pulse oximetry overestimated arterial oxygen, which essentially they did an ABG, so they took your blood and measured your oxygen level. And so essentially it overestimated 3.6% in white patients and 11.4% in Black patients. So showing us that Black patients had nearly 3 times the frequency of occult hypoxemia that was not detected by pulse oximetry as compared to white patients. And so not to say that this is a pulse oximetry is bad or that you can't trust the results, but just to show that all of these objective test results aren't always perfect within themselves, and we should always use clinical and patient-reported data as we assess our patients. And so that pulse oximeter, even if it looks like it's normal, if somebody's confused, if somebody's turning blue, if somebody has increased work of breathing, all of those things should encourage us to assess more clinical assessment rather than relying on that normal pulse oximetry, especially when there's things that could confound that result. So just wanted to share that kind of quick tidbit with you. I thought it was really helpful and pertinent and just kind of helps us help decrease the bias that we all practice with and hopefully provide better care to our residents and our patients. So moving on to our special session for vaccines. So this is a presentation for long-term care residents. I took this presentation from a bunch of different sources, from the American Medical Directors Association, from the University of Washington, from IHI, the Institute for Healthcare Improvement and Higher Logic, from the University of New Mexico, through some of our other echo experts that have given other presentations in the past, both due to COVID-19 and not due to COVID-19, to help kind of give us a lot of content that I think will be helpful in helping us understand. As we were logging on though, some of us noted that some facilities have already been vaccinated, some are going to get vaccinated tomorrow. And hopefully a lot of us already have a good idea of what these vaccines are and what's going on. And so there's a lot of things we could potentially talk about. Here in the presentation, I have these 4 kind of objectives. I wanted to kind of share these fast facts, and then we're going to move on to some quick questions, and kind of wanted to hear from the group which of these you think we should focus on today, rather than me kind of going through the whole presentation. So quickly, what kind of like I mentioned before, I've learned a lot about vaccines over the last few weeks, last few months. Still feel like I don't know a whole lot, and I'm really going to rely a lot on you guys, especially with how it's working with implementation. And we have a lot of other experts, a lot smarter than me on our call too, that will chime in. But what we know so far with the 2 vaccines that have EUA authorizations, they're both safe and effective. They both require the Moderna and the Pfizer require 2 doses before you become fully protected. And despite all of their effectiveness of these vaccines, we're still going to have to continue to practice all our infection prevention and mitigation practices. They've established vaccination priorities, and we're going to go over some of those today, and I think most of us are aware. But essentially, healthcare staff and long-term care residents and staff are on the top of the list. And so these numbers might not be completely correct. I kind of use the information from those last slides. And these numbers I think are generally better than what I'm seeing across a lot of parts of the country. But long-term care, residents in long-term care can account for up to 12 to 19% of the deaths in Nevada. I don't know if Dr. Pandora, if that sounds right to you, but it's kind of a big proportion of the people that are suffering and having a lot of more mortality because of COVID-19. Sorry, Dr. Pandora, I missed that.
You're asking me about the 12 to 19% number?
Yeah.
Yeah, I actually thought it was a little higher than that, but I wouldn't be surprised if that was correct. I'll have to double check.
Okay, cool. Yep. So other places I've been seeing 40%. Certain cities I've seen reports of it's 90% of the deaths in that city, and so very wide ranges here. So here are the common questions that we're hoping to answer through this presentation. How is the vaccine developed, approved, and manufactured? How do we know a vaccine is safe and effective? Is there new technology being used, and is that dangerous to me? What is an EUA or emergency use authorization, and what does it mean for me? Why should we trust the vaccine? When and how long will I be protected? Will I still need to wear a mask? What are the expected side effects? What if I've already had COVID-19? Where should I look to get accurate information? Where do I get residents at my care facility vaccinated? And what do we do when residents or staff refuse vaccination? So these are all the questions, have a bunch of information in here. Which of these sound most interesting for us to talk about today? Would you guys like to go through all of it or most of it, or want to focus on a few things? So I'll just kind of leave it silent here for about 20 to 30 seconds to see what the responses are. Type in through the chat or take yourself off mute, please. All right, so Maisha mentioned, why should I trust this vaccine? Julie mentioned I'm vaccinating my building right now. I can let people know what's happening. How long will the side effects, how long will it last in side effects? Most of the staff don't trust the vaccine, so why should I trust the vaccine? How long is this vaccine good for? And then want to hear more about vaccine resistance among staff. A lot of hesitancy, lots of side effects. Okay, so I will definitely keep most of the content here for those discussions about addressing side effects, effectiveness, and why. And I think, I guess my opinion and my recommendation is to take the vaccine, but I want to kind of show you guys why I came to that conclusion, because I wasn't always necessarily on that bandwagon to kind of be the first one to sign up for this shot. But at this point, I can't wait to be the next one in line. Okay, cool. Thanks for all these comments. We'll keep them coming. So So essentially, we have these two new vaccines on the market. How did they get here? What is the process as far as how a new vaccine is developed? And so this was the process that is followed for all vaccines. This includes these new vaccines that have come out against COVID-19. So essentially, they break it up into phase 1, phase 2, and phase 3 trials, where phase 1 has 20 to 100, phase 2 has several hundred, and phase 3 often has hundreds or thousands of volunteers. In this particular case, our phase 3 trials for the Moderna and Pfizer vaccines had thousands of people, and they did a meld essentially of some of the phase 2, phase 3, phase 1 trials to help increase the timeline to help achieve this EUA. So what is an EUA? It's a vaccine based on the need to quickly save lives during a public health emergency, which I think many of us can agree with that we're currently in. This is a shorter process, but no steps are skipped. So that last slide, step phase 1, phase 2, phase 3, all of those are really important for the safety and efficacy. And so you go through all 3 of those processes, even through an EUA. The FDA, the Food and Drug Administration, essentially assesses the vaccine known and potential benefits and weigh those against the known and potential risks. Once the FDA comes up with their recommendation, it goes to 2 different advisory boards who will review the data and make recommendations. And so the EUA does not imply that authorization was done too quickly or the vaccine is not safe. It's just a way to quickly get out the type of treatment people need in a public health emergency. So when people are applying for EUA, there's things that people still need to make sure all the safety precautions are done correctly. All the adequate manufacturing information. Right now, I don't think I've had an easier time finding information about a vaccine or the studies as I have with these vaccines. It's been really, really nice to see all the transparency that the company and the government has been undergoing as far as sharing this information. But would love to hear from other people, especially people more experienced with getting this information, if they would agree with that. And then also a determination that benefits outweigh its risk based on data from at least one well-designed phase 3 clinical trial demonstrating safety and efficacy. And so both the Moderna and Pfizer have done both of these things to qualify for the EUA. And this is always done on a case-by-case basis. And so essentially a medication or treatment decision. And it's really only for a specific population. I think currently the vaccinations by the CDC are recommended for older adult or for adults, and there's a little bit of, as far as whether it's 18 above, 16 above, or other ages, there's still some people that don't have complete agreement because more data is still coming. So once the EUA is authorized, it goes to essentially the ACIP looks at it and considers putting it on the immunization schedule, which kind of gives us a ways to understand how we should schedule these vaccines so that they're administered properly. Essentially here in our state, we have multiple tiers, tier 1, tier 2, on the ways we've decided to vaccinate people. Our tier 1s, tier 2, tier 3 line up with CDC phase 1A, CDC phase 1B, CDC phase 1C, which the ACIP came up with. And I circled here, number 2 on the list are most people on the call, long-term care facility staff and residents. I included the other tiers here just for your reference. So once, these vaccines, they get made, they go through the EUA, they get the ACIP makes recommendations, but essentially we still have limited doses available. And so this kind of shows the way that a vaccine is developed and administered. And so starting over here, these are just the trials where we're looking at essentially people if these vaccines are safe and efficacious. Once they are, they undergo all of the FDA, the CDC, the ACIP, all take a look at it. Production gets ramped up. This is where we are right now, where we have limited doses available and we're starting to vaccinate people. As we get more and more doses available, we'll be vaccinating more people until we reach a peak. And then at some point, the number of doses available will start to decrease to help meet some sort of open vaccination schedule where we're continually vaccinating people. So to get into the 2 vaccines a little bit more, people didn't seem too interested in this specific information, but I wanted to share it with you all because I think it's kind of the crux of the information. And so these 2 vaccines do not contain any COVID-19 virus, and I think that's really important to point out. These are mRNA vaccines. These have been used for multiple years in cancer treatment, and it's kind of an application to vaccine technology. Essentially, the way this vaccine works is mRNA is essentially a type of essentially it's a molecule that tells your body how to build a certain protein. The specific protein it's asking you to build is a harmless piece of spike protein that's located on coronavirus, and it essentially helps the body recognize this protein in the future. In case you do get infected with COVID-19, you're able to fight off that virus and not get sick. So can this mRNA vaccine give me COVID-19? It cannot. Can this mRNA vaccine change my DNA? It doesn't. And then do mRNA vaccines contain microchips? They do not. So here's some information, just, is this, was this vaccine studied in populations that are like me? As I mentioned earlier, there have been thousands of people that have been looked at given this vaccine, for over 40,000 with Pfizer and over 25,000 with the Moderna vaccine. The populations they enrolled were very diverse. 10% were Black, 13% Hispanic with Pfizer, 10% Black, 20% Hispanic with Moderna, and 45% were between 56 and 85 in the Pfizer, and 23% were older than 65 in the Moderna. And so you can see here I have up reference in our state as of 2019, 55.5% white, 8.7% Black, 29.8% of Hispanic origin. Oops. And then that's our demographic by age, where 15.1% are greater than the age of 65. Sorry about that typo there. So this is kind of the meat of it all. Did these vaccines work? You guys may have seen these numbers before, but essentially these vaccines seem to work really well. 95% with Pfizer, 94.1% with Moderna. Moderna came out with some information with 4 people that had gotten that were over the age of 65 had gotten an infection. That may have had to do with just with the actual amount of infections that happened within the whole group at all, because it didn't seem to be very much, as much as they were expecting. But these tables I really don't think speak as loudly as these graphs. I have 2 here. They look very similar, but they're the different vaccines. You can see these are all of the people included in the trial. These are the people that got the placebo shot, and these are the people that got the Pfizer shot or the COVID-19 vaccine. And you can see the number of infections or the incidence of infections over here on the left, and you can see at some point you just don't get a whole lot of infections after you've been vaccinated. And so it's really powerful to show that these vaccines really do work. And same with Moderna, you just see this rapid divergence of people over the next 2 months and their susceptibility to getting COVID-19. So this was a kind of a question that we had earlier. What should I expect? What are the side effects of getting COVID-19? Many people do get some short-term discomfort like fatigue, headache, muscle pain, chills, fever, and pain at the injection site after vaccination. These will only usually last for 24 to 48 hours and usually are worse after the second dose rather than the first dose. When you feel this way, it isn't a bad thing. It actually means that your body is making antibodies to fight off this infection. But at the same time, if you don't have those side effects, that's also okay. Not having these side effects is normal, and having these side effects is also normal. And just want to make sure we kind of clarify that. This is a quick graph. Just wanted to make sure that you guys all had access to this about the side effects related to the Moderna vaccine. And so they broke it up into mild, moderate, or severe type reactions, and they kind of qualified what those were in the literature. But you can see after the first dose, many people only had these mild reactions, some local symptoms, a little bit of myalgias. Some people had fatigue. After the second dose, you can see there's a lot more reactions, but many of them were still mild or moderate, not very many in the severe category. And so overall, vaccine is seems to be very safe with minimal side effects other than those kind of local short-term side effects that people are experiencing. Want to make sure it's clear you must get the second dose because the vaccine will not protect you if you only get 1 dose. And it's important to get the same vaccine as the first dose. So if you get the Pfizer for the first dose, you want to get Pfizer for the second dose. If you get Moderna for the first dose, you want to get Moderna for the second dose. There'll be more vaccines that come out in the future, and we'll have to kind of wait and see what all of those vaccines look like, whether it's multiple vaccines or 1 vaccine. Again, each of the vaccines have 2 doses. You get them 21 or 28 days apart. Protection occurs 1 to 2 weeks after the second dose. At this point, I know this was one of the questions, we do not know exactly how long the vaccine will be protective once we receive it. We will know as more time passes in the current research. There is a possibility that you may need to get the shot on a regular basis, just like we do the flu shot. So are these vaccines safe? And so I kind of showed you the side effect profile. You mentioned that they studied these for 2 months after the administration. And so just to kind of give you all a little bit of a history, and if any of the other, anybody else wants to speak up, feel free about the efficacy and safety of these vaccines. But most side effects occur within 6 weeks. To be more cautious, they required 8 weeks. And then they continue to monitor for safety after this distributed to the public. So all of the people receiving the vaccine now are being monitored for safety and to see if there's anything new popping up. Usually the FDA requires 3,000 participants. As I mentioned earlier, these vaccine trials included multiple participants from really diverse backgrounds, especially as compared to previous types of vaccines and their approvals. Would any of our subject matter experts want to make any extra comments about the safety of the vaccines? No?
Well, this is Mark Pandori. The fact that it's a messenger RNA vaccine is an interesting aspect of this. As you said, they had been used in cancer, but not infectious disease. So sometimes in infectious disease, one of the reasons people are afraid of vaccines is because you're actually injecting a virus. It might be a crippled version of a virus, and I think that can be freaky to consider, although they work very, very well. In this case, messenger RNA is so far away from a virus or even anything resembling a live virus that there's really no danger associated with it. One of the really neat things about messenger RNA is it is very rapidly destroyed after it's injected into the muscle. So it'll stick around just long enough to elicit the protein that'll make the immune response, and then your own body will wipe it right out. So even after about 48 hours, there's not going to be a single sign of that initial injection in your body anywhere. So it's kind of interesting. It's very nice that way, that it sort of falls right apart after it does its job.
Thanks, Mark. Yeah, one thing I was reading too is, even though this is the first time kind of being applied to an infectious disease or a vaccine, this is likely going to be the route we go for most vaccines going forward, or at least going to try.
Yeah, well, the fact that it's the code and not the proteins itself, you can change the code. You can actually change mRNA code chemically very, very easily. So if there are changes, as you were saying, next year, making changes to the vaccine code might end up being really easy to do, so that we could stay ahead of this. So it's exciting for that reason as well.
Thank you. So this is a kind of how vaccine, let me see this chat. Cool, Julie. Definitely, we're about to hopefully, do our best to address eliminating the fear associated with a lot of this, because hesitancy with vaccines is definitely real. One of the best ways, I guess, this is my opinion, to kind of let staff know that you're on board and encouraging them to get the vaccine, is to really follow up with those side effects. The VAERS is one way that the CDC follows up with vaccine safety. This particular one, I haven't seen anybody really use it. I've only heard like the CDC talk about it, but there's this vSafe app. So essentially, after you get the vaccine, you can download this app, and it will check in with you daily to track the vaccine side effects. And so really important that you follow through with a lot. Just want to make sure you're aware. And if you have side effects, follow through with these applications so that we can adequately share and discuss all of the things that are happening after we get vaccinated. And so why should we trust these vaccines? Again, they've been using these same strict standards for decades. There were no steps skipped. We had these 2 independent advisory boards that I mentioned earlier, the VRPAC and the ACIP, look at all of the data and approve these vaccinations. So why was this vaccine developed so quickly? It was a global effort with all the leading scientists focused on a single task. There was nearly unlimited resources, money, knowledge, manpower, and again, we had a really large, diverse pool of adult participants. One of the, and I guess I would defer to Dr. Riddle, but it's, from my understanding, one of the larger vaccine trials that we've had. Would that be a fair statement, Dr. Riddle? Please.
Yeah, I mean, I think these, a lot of times vaccine studies are driven for safety, a minimum safety, but then really what's driving them is the event rate of the particular disease that you're trying to prevent. And so these trials were designed they're all event driven, and they were designed to have that many events occur with an assumption of the efficacy of the vaccine. So I think one of the, like you mentioned earlier, a lot of phase 3 trials are much smaller in the lower, tens of thousands, or dozens, 12,000 or so. But these had to be larger, not only because of I think safety, but in order to get at those event rates of severe COVID disease. And so it's great that they are this large, because it gives you a lot of confidence that common concerning side effects will be detected. With these studies of around 45,000, that means roughly 22,000 or so got the vaccine. 1 in 100,000 adverse events. It's gonna take post-licensure surveillance that you described, and that's done for all vaccines. I mean, all vaccines undergo this post-licensure surveillance for these side effects, and there's just a lot of effort to look at any adverse effects, particularly because these are novel platforms that are being licensed. Over.
Thank you, Dr. Riddle. Really appreciate that. So to kind of get to more of what we all wanted to kind of talk about, and I did put these slides here at the end because I think the team knew that and is experiencing a lot of these same things that everybody else is experiencing with hesitancy. A lot of people being concerned with being first or being a guinea pig. I think that rather than being a guinea pig, I think that these are the people that are most important in our society, and are the ones that are also most vulnerable. Our healthcare workers, all of you all, and also the people you're taking care of. And so it's kind of doubly important from your standpoint, because you not only are you helping keep safe all of the residents by getting them vaccinated, based on all the safety data and efficacy data we just shared, but you're also kind of also in line too, protecting yourselves. And so you really have coming at it from two different perspectives, because you're not only looking at the residents' health and safety, you're looking at your own health and safety, and making sure we kind of take a look at both of those things holistically is super important. And I think that's part of the recommendation on why we're recommending both of these populations be vaccinated at the same time, is because of the interaction that you all have. People feel that this vaccine is being rushed. Hopefully we're able to share that overall, especially compared to vaccines in the past and compared to standards, we did go through this very quickly, but with regards to being rushed and skipping corners, as far as I could tell from all the data I looked in my experiences and all of the really smart people that I know, and I think most of the smart people on this call, I haven't asked all of them, which is why I say most. I think all of them would agree that this vaccine really wasn't rushed. I think all of the I's were dotted and the T's were crossed. And so making sure that we keep following up with these safety and side effects and these post-marketing data is super important. And we're all part of that post-marketing data. And so this is kind of part of our responsibility to help inform others if anything does go wrong. But again, it would be in a very rare occurrence that things would happen. Tens of thousands of people have had this vaccine. Rare occurrences would likely be occurring in the millions or the hundreds of thousands of people type of proportions based on what we know now. Other things that we're going to talk about that I know have been asked: how protective is the vaccine? How long does the protection last? And what is emergency use authorization? So in general, why should we get vaccinated? In general, it's to protect yourself and your family. Right now, we're not sure how getting vaccinated affects transmissibility, your ability to infect other people, but we do know that it keeps you safe from getting COVID-19 and getting really sick. And we're hopeful, and I know Dr. I think Pandori can talk about this a little bit more. I don't have too much information, or Dr. Riddle, but potentially there'll be opportunity to decrease our risk of transmitting to our residents as well if we get vaccinated. I'm not completely clear on that yet, but that's the hope. Really, we're hoping to stop the spread in the community. We'll talk about herd immunity here in a little bit, but I really want to focus on the concept of community immunity here rather than herd immunity, just because we are all across the state. And then also getting vaccinated. We set an example for others, including residents, families, coworkers, and the community at large. I don't know about your all's Facebook group, but I know I've been in medicine a little bit now, and I guess all I've been seeing for the last 2 weeks are all my colleagues getting vaccinated. all the ones that work in the hospital or nursing homes or long-term care centers. They're all really proud of the vaccines that they're getting, and it definitely is encouraging me. And when it's my turn in line to get the vaccine, hopefully that I will definitely be signing up. So the next question, well, I'll see some things coming through the chat.
Yeah, I've been answering some questions in chat. I don't know if that's okay, Dr. Lynn.
Perfect. Thank you, sir. Appreciate that. How long we will be testing our staff? Yeah, so I think this is kind of getting to the next thing is, even though we're all getting vaccinated right now, until we reach a certain point to be decided in the future, all of the things that we've talked about in the last 7 weeks and all of the things that we'll be keep talking about over the next 10 weeks are still going to need to happen until a certain threshold is reached, and that it's very unclear when that threshold is. And so we're all going to still have to wear masks. We're still going to have PPE. Still going to have to keep your quarantine units, your observation units, your COVID-19 units. Especially you guys will be admitting new patients as well. Long-term care does have turnover, maybe less so than before. Tough for me to say, but it's definitely going to be picking back up, especially as these vaccines start happening, and figuring out how we're going to be applying all of these things that we've been doing to these people that have the people that have been vaccinated, some people that haven't, some people that won't get vaccinated. These will be really important for us to think about and think through. So herd immunity, just want to I'll probably spend a lot more time here because I think it covers a lot of the topics that we're looking for to cover. But herd immunity is really a concept related to vaccination. Essentially, it was described when a population can be protected from an infection when a threshold of vaccination is reached. As far as I was looking, and I see people talking about this often, I'm not sure I've heard of too much herd immunity happening from natural infections. With mutations and reinfections that have been reported, it might be difficult for us to achieve COVID-19 herd immunity through natural infections alone. Vaccine-mediated immunity can have longer and more lasting effects compared to natural infection. So even though we get, for those of us that have been or can be infected with COVID-19, many of when we look at previous diseases like tetanus, measles, when we get vaccinated, it offers us longer immunity compared to when we just get the natural infection. And before we reach herd immunity, we have to reach a certain threshold of people that are immune to the disease. And it seems that this threshold isn't the same for every disease. And so it can be as high as up to 95%. I was reading for some specific diseases, and I think they mentioned measles, which is why we saw some of those outbreaks in the Northeast in New York over the last few years because of people getting measles and bringing it to a community that doesn't otherwise have community immunity because all of those people in that community were not vaccinated against that disease. And so when one person brought it, something that was highly contagious, highly transmissible, spread to everybody else. All of us working in nursing homes, long-term care facilities, the term community immunity I think is super important because what we're really trying to do is look at the people around us, look at the people we're taking care of, and have a better idea of how we're going to keep our community safe. How are we going to keep our community immune from COVID-19? Vaccines are a great step, and we'll kind of talk about how important of a step here they are at the very end. But really focusing on how we're going to keep our community safe rather than kind of this herd immunity, because it really doesn't personalize your role in herd immunity when you say it that way. But when you say community immunity, we all are part of our communities, and so making it a little bit more centered, a little bit more at home can be important. So a couple special circumstances. It's safe to get the COVID-19 vaccine if you've had COVID-19. I think Dr. Pandori answered one of those questions. Even if you've had COVID-19, it's important to get vaccinated. As I mentioned earlier, it could give you longer or better protection against the disease. Even if you're positive for COVID-19 antibodies, you should still get the COVID-19 vaccine. And then if a resident has been recently treated with a monoclonal antibody, delaying vaccinations for 30 to 90 days could be reasonable. It would be just the one comment to make there. Here I have a little bit more information about pregnancy. In the vaccine trials, they did not include anybody that was pregnant, but there were some inadvertent pregnancies, I think they were described during the trials. And so there were a few women that got pregnant, and they're kind of following those results. At this point, the American College of Obstetricians and Gynecology recommends that COVID-19 vaccine should not be withheld from pregnant individuals who meet criteria for vaccination, nor should they be withheld from lactating individuals. As Dr. Pandori mentioned, at this point, And I don't think, and my guess is this won't change, that vaccine stays where you injected it. It doesn't go much farther, and so offers really little potential harm to the mother or the developing child. So quick, so this is a quick overview of the distribution and administration. This kind of goes over the supply chain, essentially the administration or the development, the administration, and deployment of all the things needed for the vaccine, from supplies, manufacturing, kitting, distribution to partners. And this is really where we are now, the last mile, the last bit of the supply chain, where it's going to pharmacy, long-term care providers, multiple other hospitals. And really the cold chain also comes into play and probably plays a big role in how you guys are all thinking about this, because these vaccines need to be kept cold. And once they're defrosted, they're only, especially the Pfizer vaccines, only used for a very short amount of time. And so kind of keeping all that in mind as far as this big process before it gets into our arms is super important. So talking about a little bit more about vaccination in Nevada, I guess at this point would want to hear from the group about their experiences getting vaccinated, rather than me continuing to talk. I guess, was it June or Julie mentioned that they're...
Yeah, it's Julie. Walgreens is on site here today, vaccinating all of our staff and residents. And actually it's been, the situation itself has been very positive. They've been they explained everything. They've worked with everyone quite well. And, you know, I think we've been talking with our staff with the anticipation of this happening just about every day for the last 10 days. And we seem to have gotten a pretty good flow of staff to take it. Some are waiting. How they're working it out, of course, is with 3 times that they come to the building. The first one is today, where we're doing half the staff approximately, and then all the residents that are going to take it, they'll come back in 2 weeks or so, when 28 days or whatever, they'll come back and do the second part of the staff and the second injection for those of us that took it today. And then the third trip will be the second injection for the group that takes it the next time around. So everybody in the facility should be vaccinated by the middle or so, or the end of January. And I have to say, I think it's been absolutely positive. They're a good group of people. We have pharmacy on board. We have their pharmacist who is here monitoring everybody very closely. They're very, very consistent on how it goes. You get, you fill out your consents, you go in, they give you the injection, and they monitor you for 20 to 30 minutes afterwards, and they don't take their eye off of anybody. That's a very critical part to this, they're telling us. And so far we have not had one issue that I know of in the building. We're still going. We still have a few residents left to go yet today. Staff have taken it wonderfully. Some that weren't going to take it have taken it after speaking to those that have taken it, or talking to Walgreens, and watching the rest of the staff take it. So currently it's been nothing short of a positive situation for the facility. So so currently, somebody asked, I see that there were 4 techs and a pharmacist are here for our building, and we are a 98-bed building, and approximately 100 or so staff, give or take here and there. So it's been going on since 8:30 this morning. It took them a little bit to get started because this was their first one as well in the Las Vegas area, I believe. So they were kind of getting set up and figuring out their flow too. But I think once they figured that out, it started going a lot smoother for everybody. Again, the difference is I think they thought possibly coming in that they could go, and the residents would come to them as well. You set up like a clinic type thing, which we did. They send you a chart on how to do it, and we set everything up. However, we have a vent unit and other things, so people are not so easily transferred to this little clinic. So they are going through the house right now, giving those injections with our staff. So a few little quirks, like they have entrusted our own staff to monitor those residents as they go through the hallways, because they can't possibly get it all done any other way. But if you are a building where residents are able to transport themselves, or you have assistance into a clinic type area. That's what they would certainly prefer. There's no doubt about that, because there's a lot to be done with this.
Cool. Thanks, Julie. Appreciate that insight, especially the differences between our mobile and our less mobile patients. I think there was a question. Sorry.
Can I just ask a question, Modi? Julie, did you give vaccine to anyone, staff or resident that it was known COVID positive previously?
Oh, yeah.
All of us.
Yeah, we had a earlier outbreak back in April in this facility, and a lot of staff at that point. Knock on wood, we haven't had that, sort of outbreak, but yes, we've had some residents and more recently in the last month or so back. So yes, several people that have had.
I don't think that deterred anybody.
No, it didn't deter. I'm sorry, I'm talking about Terry Wright is also in here with me, but yes, it didn't stop anybody from taking it. Once they said everybody should take it, everybody did.
But the reason I ask it that way is CDC is recommending if you are known COVID positive, that you should not take the vaccine, or you should wait 90 days to take the vaccine. So that's why I just asked.
That would be about right for our staff currently, that it would be
Perfect.
over 90 days. That would be correct.
Perfect. Okay. And the reason is that they aren't certain that you'll mount as good a response.
Right.
I don't know if Mark, you want to comment on that, or Modi?
Yeah, I mean, I think it's largely based, kind of theoretical in what we understand about the immune response. Clearly, the shots that are 21 and 28 days, you're going to have antibodies based on that first response when you get the 28-day response. And so they're not saying, you don't need to wait that 3-month interval. I think that the guidance on the 3 months is that it's better to wait so that you don't have circulating antibodies. In fact, if you look at developing a good memory response to vaccines, the longer you wait between a priming and a boosting shot, the better your memory response is, and your recall when you see that infection again. But I think the other factor is that we've not seen reinfections in that first 90-day period, that the reinfections seem to occur after that 90 days as well. So I think it's not an issue of safety. Could be an issue of efficacy, probably not, but I think the CDC guidance is a great guidance to follow. And the other thing to point out is that you don't need to do any testing before you give the vaccine. So you don't need to know whether somebody has it or not either.
Yep, and just quick, you don't need to do any pregnancy testing either before providing the vaccine, since that was mentioned, at least. And then the other, there's Hope had a couple great questions. I think some of them you answered. I think you mentioned you had 4 techs come, Julie, is that right?
Yes, Walgreens supplied the 4 techs and a pharmacist. That's correct.
And then did you provide any fridge space? Sorry, Mark.
Yeah, no, go ahead.
Oh yeah, Julie, did you provide any fridge space?
I'm sorry. Oh, we had one, but they didn't use any. Pardon me?
They had their coolers.
Yeah, they had their own coolers. They came in with everything. So actually they didn't use it, although we provided one in that room. No.
Okay. Did they have EpiPens on hand?
Yes.
Yep.
Yep. And then did you have any extra staff today?
No, actually we didn't. And they're so helpful. I don't know how else to explain it, but what a partnership. I mean, hats off to Walgreens. I don't know, I think for being brand new and starting with us the way they did, and us being new, and we tried to anticipate. They sent us a diagram last week and in an effort to try to have it set up and ready to go the way they thought it would work, and we tried to follow that, and actually it worked out quite well. The biggest issue that they are concerned about is having that separate space and monitoring the staff after the injection for that 15 or 20 minutes or so. And she was very clear with me that was critical. So, but there's nothing I can say but congratulations to Walgreens, and what a partnership in a difficult situation.
So this is Mark. I think a wonderful presentation and information. I think to focus on things that we don't know, and I think it's important for this population. One is we don't know if the vaccine will reduce the transmission. Somebody could still get infected and be able to transmit the virus to others. We don't know that. We don't know truly the immune response in the elderly, right? We don't know in the 70 to 80-year-olds. That most of the data is from, they stratify it greater than 65, but we know with immune senescence that your immune response to vaccines go down over time, or as you age. But the preliminary data and the phase 1 data show really robust immune responses in the elderly. So it's very encouraging. Then the other thing that comes up often, and we just don't know, is that people on immunosuppressants were not included in the original phase clinical trials. It's not a safety issue because these aren't live vaccines, and it's not a worry about safety. But with any immune suppressed individual, it's just hard to know what their immune response is going to be. These are unknowns. These are being studied right now. Many people are keen on these questions, and I think answers are forthcoming to help us with these unknowns. But on the balance, even with these unknowns, it makes sense for vaccinating these vulnerable populations and the staff that take care of them, but also maintaining physical distance and masking and things, because we don't know some of these other questions. I'll stop there.
I do think we need to generate some clarity, though, with regard to this. If you've had COVID, should you get the vaccine? The answer, the CDC, at least, is unambiguous that you should. But hearing what you said, Mark, about 90 days might, because now someone's asking on the chat whether they should wait 14 days. And, the CDC, at least if you go to their main COVID-19 vaccine website, they don't specify any time frame or anything like that. They just say,
I think 90 days is and a bit, again, because I think two reasons. One is we know that infection doesn't reinfections don't occur within that 90 days, and then secondly, to just on a vaccinology kind of a basis of how vaccines work, the longer you wait between that first and that second, a natural prime and a boost, you're going to get better immune responses. And so I think the 90-day time frame is fine. The vaccines have been developed with an accelerated. They don't want to wait that 90 days. They want to get your prime and your boost in as quickly as possible. And so that's why the vaccines have been developed with the 0 and 21 or 0 and 28 regimen. But again, if someone's had COVID vaccine or COVID infection, there's natural protection for at least 90 days, and waiting 90 days and then getting the vaccine makes perfect sense.
well, the documented reinfection cases are less than 90 days, though, in the literature. But so I'm not sure where the number comes from. But I just think people are going to be a little confused by that, because CDC is not really actually giving that messaging. So I don't know how that's going to turn out.
I think logistically, theoretically, I guess that these people from Walgreens are coming on one day, and it's talking to Julie, they're going to come again 3 weeks later, and then again 3 or 4 weeks later. And so I wonder how easy it's going to be to get multiple visits for these vaccines, depending on the setting that everybody's getting vaccinated in, and wondering if that's going to be a bit an important logistical barrier, because none of us are getting any younger, right? I'm younger now than I will be in a month or 2 months. But wondering, if there's, that benefit from getting vaccinated now because it's available versus having to wait another 2 months for the next time for it to pop around is worth a conversation.
So Dr. Pandora, I would direct you to the interim considerations of COVID vaccine for healthcare personnel and long-term care facility residents, where it states that healthcare providers with documented acute SARS-CoV-2 infection in the preceding 90 days may choose to delay vaccination until near the end. So they're not saying that you have to, but the guidance is that that 90 days waiting after a confirmed COVID infection.
Strange. Okay,
So,
may choose.
So that's from the CDC vaccine recommendations, interim considerations guidance.
Okay, because what I'm looking at is their facts about COVID-19's vaccines at their COVID-19 webpage. You know, there's a facts about COVID-19 vaccines that they have, and they talk about whether you've had this before. But I don't know, this wouldn't be anything new to have mixed messaging on this.
Yeah. So I think this brings up a great point. And if Dr. Riddle, if you could throw that link in the chat for everybody. Lots of misinformation out there with regards to where we should be getting our vaccine information from. So here's 3 websites for you that'll be sent out later from the CDC that they're hopefully keeping updated. And we'll be also sending out some other great resources here at the end as well. I think we're running a little bit out of time. Sneha, if you could send out that last poll for us that we ask, and then we'll spend the rest of the time. I guess quick updates. Troy, sorry, I'll just kind of we're going to be skipping next week, so we'll see you again on January 4th. Last time everybody decided to take a holiday, or most of us decided to take a holiday on December 28th, and so we'll be back on January 4th to talk about. I believe it was. Let's see. Oops, lost the sharing. Let me just pull it up here. COVID-19 community transition and nursing home screening strategy. So still very pertinent topics for what we're all going through.